Hi guys, we're Cardiac Group 12 and we're going to be covering unstable angina. My name's Claire.
My name is Anna.
My name is Vivian.
And my name is Rachel.
Thanks for watching.
So here is the case study. John Smith is a 55 years old Australian male. His height is 188 cm and weight is 124 kilograms. He is an owner of Meat Delight who came to ED this afternoon after a sudden episode of chest pain when he was talking to his business partner. He has hypertension, high cholesterol, obesity, and type 2 diabetes. He has no past surgical history. John's father died of heart problems at the age of 60. He smokes 1 pack of cigarettes per day, drinks 6 to 7 beers per night while he watches his footy. After his divorce, he started to eat out takeaways and drive through at Macca's. He doesn't do exercise and drives to and from work. Here is the vital signs. Blood pressure 150 or 90. Heart rate 125 beat per minute. Respiratory rate 23 breaths per minute and it is shallow. Temperature is 37 degrees Celsius and O2 saturation is 93%. Mr. Smith describes the pain as heaviness and tightness as it radiates to his jaw and neck. He also felt burning sensation in his chest, felt nauseous and sweating. He also has shortness of breath. From the result of ECG, ST segments depressed and T wave inferred. No cardiac markers found in blood tests, and there has blockage shown in chest X-ray and angiogram. During stress tests, John got pain on exertion.
Mr. Smith has been diagnosed with unstable angina. Therefore, to understand management, we need to understand its pathophysiology. However, I have a few points to review before we discuss it. Understanding these core fundamentals is essential in order to learn about unstable angina. Every cell needs an oxygen for proper functioning. No oxygen means death to cell. As we know, heart is made out of smooth muscle cells. Thus, these cells also need oxygen to do their job. So what's the job? The job of the heart is to pump the blood in the human body. So at the same time, it is responsible for delivering the oxygen to all of the tissues. But the blood that heart pumps doesn't reach to the myocardial tissue. So within the heart, there's a special circulation called coronary circulation that is responsible for it. So the question is, what happens if there is not enough oxygen delivered to cardiac cells? And what causes this impairment and how is it manifested? Let's start with explaining what is an acute coronary syndrome. It is an umbrella for range of conditions associated with reduced blood flow to the myocardial cells. The syndromes are on spectrum from unstable angina to myocardial infarction. It occurs when plaque builds up in the coronary arteries. As mentioned before, they supply oxygen-rich blood to your heart. Plaque narrows the coronary arteries and reduces blood flow to your heart muscles. Plaque build-up also makes it more likely that blood clots will form in your arteries. Blood clots can partially or completely block blood flow. If blood flow to your heart muscles reduce or block, you may have angina or even a heart attack. As I mentioned before, heart cells, like any other, need oxygen that is delivered from coronary arteries. If demand increases, they dilate to increase blood flow. However, narrowing of the main arteries interferes with adequate oxygen supply and impairs cellular metabolism, which can lead to myocardial ischemia. So simply saying, when the heart cells don't get enough oxygen, it results from ACS. But what leads to formation of the plaque? It is atherosclerosis, a chronic disease of arterial system. It starts with an injury to the endothelial cells that are in the artery walls. Some examples of possible causes including hypertension, diabetes, smoking, increased low lipoprotein cholesterol levels, and decreased high-density lipoprotein cholesterol levels. These damaged cells become inflamed, thus they lose ability to prevent blood clot formation and vasodilation. This leads to aggregation of platelets and release serotonin that causes vasoconstriction, thus blood flow decreases. At the same time, sympathetic nervous system activation contributes to vasoconstriction. Following this, inflamed endothelial cells make molecules bind monocytes, which enhances further damage by releasing inflammatory cytokines. Accumulation of macrophages with LDL are called fatty streak, and they result in progressive damage to the blood vessels. Smooth muscles, cells, and collagen fibers move over to the fatty streak, forming a fibrous plaque. This makes blood vessels gradually narrowing the arterial lumen and limiting blood flow to distal tissues, and this leads to angina. So simply saying, it is an abnormal accumulation of lipids in the coronary vessels that cause narrowing the blood flow. They become thickened and harder, and it leads to decreased oxygen delivery to smooth muscle cells of the heart. The cause of atherosclerosis is unknown. However, certain traits, conditions, or habits may raise your risk for the disease. These conditions are known as risk factors. You can control some risk factors such as lack of physical activity, smoking, and unhealthy diet. Others you can't control, such as age or family history of heart disease. Some people who have atherosclerosis have no signs or symptoms. They may not be diagnosed until after a heart attack or a stroke. So let's talk about unstable angina. It is a form of acute coronary syndrome that results from reversible myocardial ischemia. As I mentioned before, atherosclerosis leads to formation of fibrous plaque. Sometimes they can be unstable, which means they are vulnerable to rupture, even before they affect blood flow extremely enough to be detected. After the rupture, tissue under are exposed, which results in platelet adhesion and coagulation cascade. Thus, thrombus formation appears. This thrombus is unstable and may occlude the vessels for no more than 10 to 20 minutes, with a return of perfusion before grave damage occurs that can lead to myocardial infarction. Unstable angina is a new onset angina that occurs at rest, or just angina with increased severity and frequency. Often dyspnea, which is difficulty in breathing, and diaphoresis, which is excessive sweating, occur along with the pain in chest. Most commonly, people with unstable angina will progress to myocardial infarction. If thrombus doesn't break up, it will lead to prolonged ischemia, causing lack of oxygen and nutrients to myocardium. Thus, heart cells will die. This is an acute myocardial infarction. Mrs. Smith presents most common signs of unstable angina, including chest pain that occurs without increased physical activity and that radiates to the neck, back, and arms, sweating, nausea, and shortness of breath. If left untreated, it can lead to heart attack, heart failure, or arrhythmias, and these conditions are life-threatening.
Pharmacological interventions. The first drug is aspirin. It's to prevent thrombosis, reduction of myocardial infarction risk. Its contraindications are individuals with NSAIDs-induced sensitivity, bleeding disorders, hypersensitivity to the drug. Side effects can include nausea, GI distress, GI bleeding, increased bleeding time, hearing loss, and bruising. Care considerations. Don't substitute it with NSAIDs. It can relieve pain, but it won't affect blood clotting. You should take the drug with food, milk, or a large glass of water. This is to reduce adverse GI reactions. Captopril is to treat high blood pressure and heart failure by lowering blood pressure to normal levels and reducing the risk of heart failure. It may be addicted to other ACE inhibitors Side effects include dizziness, headaches, aching or muscle weakness, a taste change, dry cough, nausea, or vomiting or fatigue. Care considerations are monitoring blood pressure regularly to inform the doctor if patient shows any chest pain, swelling face, eyes, lips, tongues, arms, or legs, and difficulty breathing. Metoprolol. It's a beta blocker that works by blocking the effects of adrenaline, the heart beats slower and with less force, reducing blood pressure. It relaxes blood vessels and open up to improve blood flow, and this prevents angina. It should not be used in patients with heart rates below 45 beats a minute and a systolic blood pressure below 100. Side effects include bradycardia, heart failure, AV block, and bronchospasm. The care considerations to be cautious with patients with heart failure, diabetes, respiratory, or hepatic diseases, and elderly as well. It is important to monitor the apical pulse, blood glucose levels, and blood pressure. Atorvastatin is to treat high cholesterol, reduces LDL, cholesterol, and triglyceride. Patients that are hypersensitive to the drug or have active liver disease or elevation of transamine levels should not be taking atorvastatin. Side effects can include headache, abdominal pain, diarrhea, back pain, rash, infection, or flu-like symptoms, and including allergic reactions. Care considerations include history of liver disease or heavy alcohol use. It should be withdrawn if risk of renal impairment, endocrine, or electrolyte disorders. It's indicated after a start of a low cholesterol diet.
For nursing intervention, we have 5 main approaches. First, close monitoring. Second, pain management. Third, ongoing assessment. Fourth, non-pharmacological management. And last, lifestyle management. For close monitoring, nurses have to obtain Mr. Smith vital signs, including blood pressure, oxygen saturation, body temperature, pulse, and also respiratory rate every 30 minutes. It can confirm feedback on treatments performed and provide critical information. For example, increased respiratory rate may indicate the presence of pain and anxiety. Secondly, monitoring if there is any cardiac rhythm changes in ECG every 30 minutes. It can give evidence of cardiac damage. Thirdly, closely monitor for signs and symptoms such as dyspnea, nausea, and vomiting and dizziness. Worsening symptoms are lethal as it may indicate the early signs of heart attack. Fourthly, assessing if there are symptoms of pain such as facial grimacing, rubbing of neck or jaw, because the level of pain can indicate the effectiveness of previous treatments such as medication. Also, it is important to instruct the patient to notify the nurse or doctor immediately when experiencing any pain. Lastly, checking his skin temperature and peripheral pulse frequently. It promotes efficient tissue provision as he is generally rests in his bed or chair in the ward. For the second nursing intervention, pain management. Administering analgesia as ordered, such as morphine and aspirin, if pain is endurable. The analgesia have several beneficial effects. For instance, it causes peripheral vasodilation and therefore reduces myocardial workload. Also, it has a sedative effect to produce relaxation and thereby effectively relieve severe chest pain. However, notify the doctors if the chest pain is getting worse or cannot be relieved more than 15 minutes. For ongoing assessment, it is important for nurse to assess patient cardiac rhythm with the 12-lead ECG. It provides a baseline against which to compare later pattern changes, and serial ECG changes can give evidence of cardiac damage. Secondly, take blood tests regularly. It checks if there is any elevation of troponin level or changes in cardiac enzymes, which may indicate myocardial infarction. Also, it can be served as an initial screening tool for abnormalities in lipids, such as cholesterol and triglycerides. High cholesterol levels often are a significant risk factor for heart disease. Thirdly, ask him to rate his chest pain on a scale marked from 0 to 10, where 0 is no pain and 10 is the worst pain. It measures his pain intensity, and analgesia can be given to relieve the pain. Lastly, a routine angiogram can be given, which takes approximately 30 to 45 minutes. It is a non-invasive procedure which provides an elevation of coronary artery disease, which is CAD, and can be used to check the severity of CAD. For the fourth nursing intervention, non-pharmacological management. Firstly, maintain quiet and comfortable environments, for example, restricting visitor as necessary, because mental or emotional stress could increase myocardial workload. Secondly, providing oxygen to Mr. Smith if his oxygen saturation is below 94%. It maintains adequate oxygen supply for myocardial uptake, which reduces the risk of heart attack. Thirdly, keeping the back rest elevated to keep the head elevated too, and change his position frequently. It improves tidal volume as it reduces the pressure from the diaphragm, allowing better lung expansion and gas exchange, which can improve his shortness of breath and also the chest pain. Lastly, providing him essential information about his unstable angina in order to alleviate fear of unknown. Also, nurses can provide printed material for him to easily review. This interaction can help establish trust and also let him to feel less anxious. It decreases the sympathetic stimulation, which can then decrease the workload of the heart and ease oxygen demand.
The fifth and the last nursing management is lifestyle management. We can manage it in different aspects. First, weight management. Nurse should check daily weight on John and suggest him to check it once a week after discharge. It can reduce the risk of death in coronary artery disease and to achieve favorable effects on blood pressure and glucose metabolism. Secondly, diet management. Suggest adequate amount of nutrition intake and to limit alcohol consumption, limiting the energy intake to maintain a healthy weight, which associate with beneficial effects on cardiac risk factors. Dietitian can be included to customize the most suitable diet for John. Thirdly, physical activity. Encourage John to do aerobic exercise progressively, incorporate into daily activities which is bearable for him. Regular physical activities decrease the mortality and morbidity rate on patients with CAD. Nurse can refer John to physiotherapists to determine appropriate exercise for him based on his ability. Lastly, smoking. Advise John to quit smoking, explain how smoking can worsen his situation, and the use of pharmacological aid can constantly improve the cessation. Stop smoking has been reported as it is the most effective for a patient with CAD. Cessation assistance can be included to provide follow-up assessment and advice after John discharged. Montolesco, ETAL 2013.
NSQHS. Standard 2. Partnering with consumers. Nurses can encourage John to actively participate in discussion of his situation to improve his experience and result in a positive outcome. Standard 4. Medication safety. To ensure medications are administered correctly to John and educate or inform him all the contraindications, things that need to notice when taking the medication. Standard 5. Patient identification and procedure matching. Before any procedure or medication administration, nurses need to ensure that correct identification of the patient and with the correct treatment. Standard 9. Recognizing and responding to clinical deterioration in acute healthcare. Nurses should recognize and provide appropriate and timely response to any deterioration of John, as well as inform John and his family about the situation.